Hi, this is Dr. Christopher Ellingson with OrthoVirginia, and I'd like to welcome you to our Facebook Live today. For those of you who might not be aware of what OrthoVirginia is or who we are, we're the largest subspecialty orthopedic group in the state of Virginia. We have offices throughout the state, including Northern Virginia, Richmond, Lynchburg, Southwest Virginia, and here in Norfolk and Chesapeake, which is where I practice. I am a orthopedic sports medicine subspecialist, and as part of my training, have been fortunate to take care of patients with hip problems, specifically patients with hip impingement and labral tears, which is the topic of our discussion today. When we talk about hip impingement and labral tears, we see patients in clinic with hip pain that can come from many different areas. When we evaluate somebody in clinic, we can usually get an idea of where their hip pain may be coming from simply by having a good discussion in terms of their history, as well as doing our physical examination. But when we see patients in clinic, we really have to sort out where their pain may be coming from either sources within the hip joint itself versus sources outside of the hip joint, which can include some of these listed on the slide here. We're talking specifically today about a condition within the hip joint itself called hip impingement or femoroacetabular impingement, and the resultant labral tears that oftentimes occur within the hip as part of that process. When we talk about hip in general, the hip anatomy, the hip is a ball and socket type joint. The ball is the femoral head and the socket is called the acetabulum. Around the rim of the socket, there is a soft tissue called the labrum, which is a piece of cartilage that essentially forms a seal around the ball or the femoral head, and has some function in terms of maintaining good health within the joint itself, as well as some proprioception or some nerve feedback for the joint. And when we have injuries to the labrum itself, those injuries can cause pain associated with that labral tear that we'll be discussing. So what is hip impingement? Hip impingement or femoroacetabular impingement is a condition in which there's a slight asymmetry in how the bone was formed, specifically the junction between the ball and the neck, which is part of the femur. And in this view, we can see that there's two main types of impingement that can occur. There's one called a cam impingement, which is simply a prominence or a bump on the femoral side that as we flex our hip up and rotate, that bump can engage the edge of the acetabulum or the edge of the socket, resulting in symptoms associated with hip impingement, as well as associated with some of the labral tears that we see. The second type of impingement that we see originates from the socket side in patients that may have a socket that is deeper than normal or sometimes rotated slightly that places them at risk for developing the hip impingement symptoms. So who has hip impingement and who gets labral tears? We typically see hip impingement patients presenting in their young to middle age, but this is a spectrum of patients that can occur anywhere from your teens up into your 50s and 60s. And so I take care of patients of all ages, but the larger percentage tend to be in their 20s to 40s when this becomes symptomatic. Patients will oftentimes report pain that they feel mainly deep in the front of the hip or in the groin almost, particularly with specific positions or activities. A lot of patients will describe their pain with what we call a C sign, which is something we kind of talk about when I evaluate somebody in clinic, but they'll oftentimes report pain with specific positions such as squatting, going up and down stairs. Long sitting is oftentimes a complaint in terms of like long car rides or sitting at a desk. They also notice it with certain rotational movements like getting out of a car or twisting and rotating and squatting down. Hip impingement is something that certainly has been recognized more and more in terms of being a condition that patients have, but these patients oftentimes go for a period of time being treated for a hip sprain or hip bursitis or some other condition that may not actually be an accurate diagnosis, and some of them have been treated for fairly extended periods with either activity modification, anti-inflammatories, or physical therapy prior to being actually diagnosed with hip impingement or a labral tear. So how do we evaluate somebody with hip impingement or a labral tear? Most of it actually comes down to the initial visit here in clinic. We can usually get a very good idea of what the pain generator may be or where the pain may be coming from based simply on the patient history in terms of when the pain began, what type of activities, movements, or positions may cause their pain, and what type of treatments they've undergone. Part of the evaluation certainly is performing a physical examination. There are certain maneuvers during examination that can be very indicative of hip impingement or a labral tear. And so we certainly try to correlate what the patient has been describing in terms of their symptoms to what we see on their physical exam in terms of the diagnosis. X-rays are usually part of the process as well. We look at specific X-rays to look at the overall bony alignment of the hip to see if there's some evidence for this hip impingement from a bony standpoint. We also get X-rays to make sure that there's not some other issue going on, such as arthritis, that could be causing some of the hip symptoms. An MRI can be useful, though not always necessary in terms of diagnosing hip impingement itself. That diagnosis can usually be made simply by the physical examination and the X-rays. The MRI is very useful, though, for evaluating the overall health of the cartilage within the joint and specifically the labrum to see if there's evidence of a labral tear within the hip joint. And then part of the workup may also be undergoing a diagnostic injection where we inject some numbing medication and maybe a little bit of some steroid into the hip joint itself to see what kind of a response the patient may have with that injection. With the patients who report their pain having improved, even for a short period of time, that usually correlates then with them having pain that comes from the inside the hip joint itself. And so a diagnostic injection can be part of the overall process in terms of working up somebody who has hip impingement or a labral tear. So how do we treat hip impingement and labral tears? Usually there is a period certainly of non-operative treatment that we undergo. That can include modifying some of the offending activities, modifying your overall workouts or routine if needed. However, obviously we don't want to necessarily shut down and not be able to do the activities we enjoy, and so there's a little bit of a balance there. We usually will send patients for a short course of physical therapy to identify any areas of weakness around the hip or the core musculature. We really want to work on core strengthening and hip strengthening as part of the process. And we may work on overall flexibility, although that tends to be less helped due to some of the bony mechanical impingement that occurs from the anatomy. The short-term use of some anti-inflammatories can be a benefit, and again, the injection occasionally into the hip joint as a diagnostic tool. So if we have significant improvement with our non-operative treatments, that may be all a patient needs. However, if somebody has ongoing symptoms that are causing significant dysfunction in terms of their overall activities, and it happens frequently enough where they can't do the things they want to do, we may enter a discussion about whether surgery would be appropriate. That surgery would be a hip arthroscopy or hip scope procedure where we go in through a couple small incisions around the hip joint itself into the joint to evaluate the labrum, perform a labral repair, which we see on the slide on the right here shows a labrum after it's been repaired with some stitches in it. Part of the process also is to work on the bony impingement part of the issue. And so the focus of the surgery is kind of twofold. One is to fix the labral tear, but number two is to take care of the underlying bony impingement that's causing some of the pain and may also cause the labral tear itself. And so if we look at this slide here, we see on the left, before surgery, the prominence of the head-neck junction or the cam lesion, and on the right, after surgery, how it's been reshaped by taking some of that bone away arthroscopically. And so that process is a hip arthroscopy or hip scope surgery, which is surgery that you come in and go home on the same day from. In terms of postoperative recovery from a hip arthroscopy or hip scope, patients are allowed to put weight on their leg right away, but we keep them on crutches for 3 to 4 weeks to let some of the tissues around the hip joint heal properly. Most patients by 3 or 4 weeks are coming off their crutches and walking normally. We will usually initiate physical therapy within a week to 10 days to work both on range of motion as well as some gentle strengthening. Most patients are allowed to get on a stationary bike within the first 3 to 4 weeks. We transition to more strengthening and possibly an elliptical machine at around 8 weeks. Usually no impact running or jumping for the first 3 months, but at the 3-month mark, most patients are allowed to slowly progress and add back in activities as they tolerate under the direction of both their surgeon and the physical therapist. And most patients will see an overall full recovery or a full return to function at around the 5 to 6 month mark. So in review, again, I think if you have an issue with hip pain that you're unsure about, it is important to get in and be evaluated by an orthopedic physician. Certainly having somebody who specializes in sports orthopedics or hip impingement or hip labral tears may be a benefit. There is usually a period of some non-operative care, even if you have a labral tear. And there are some things we can do to hopefully improve your overall symptoms and function, which can include even a surgery. At this time, I'd like to open it up to any questions that you may have.
Thank you so much, Dr. Ellingson. We have some questions that came in ahead of time. We are also looking at the questions that you are submitting now in the Facebook comments. So one of the questions that we have is there a certain time frame for an intervention before it is too late to treat a labral tear?
That's a good question. We oftentimes will see these labral tears that have been there for a prolonged period of time. I wouldn't say that there's necessarily a single time frame after which the labral tear is no longer treatable. There are some risks in terms of the labral tear progressing or becoming more significant. And there's some risk in terms of the labrum itself becoming somewhat more frayed or degenerative, which can make a repair more difficult. Additionally, occasionally the labrum itself can become somewhat calcified or hardened, and those patients then are not really a candidate for labral repair per se. They get more of a cleanup, if you will. But the vast majority of patients who have a hip arthroscopy do have a labrum that's repairable, and we certainly focus on trying to attempt to repair if we can. There's a very small subset of patients, if they have a very chronic tear that has calcified and is not repairable, that may be a candidate for a little bit more of a more complicated or complex hip arthroscopy surgery to reconstruct the labrum, but that's more the exception rather than the rule. Again, the majority of patients have a fixable labrum, and whether we do it, within a month of seeing them or within the 6 months, it's usually about the same surgery, and so it's not an urgency necessarily. It really comes down to whether the hip itself is symptomatic enough and causing enough dysfunction that a patient wants to consider the surgery.
Thank you. Is there an age limit on repairing a labral tear?
No, there's not a specific age limit. There are factors that play a role in whether a patient is a good candidate for hip arthroscopy. I do hip arthroscopy in patients in their teens into their 60s. And really the more important aspect is not necessarily somebody's age, but whether they have any underlying osteoarthritis or arthritis within the hip joint. If somebody does have underlying arthritis, there is a tipping point at which a patient is no longer a candidate for hip arthroscopy. And that's something we certainly evaluate both with our x-rays here in clinic, as well as with any MRI that might be done. That can help guide us in terms of being able to counsel a patient whether they would be a candidate for hip arthroscopy or hip scope versus needing consideration for a different type of treatment like a hip replacement or some other treatment.
Thank you. Can the impingement or the labral tear affect range of motion? For example, being able to get into a yoga pose on one side of the body, but not on the other side?
Absolutely. Part of the process with this hip impingement is there is a bony blockage or impingement that can limit some of the range of motion. We will notice that oftentimes with both hip flexion as well as some of the rotational movements of the hip. Most patients have a relatively long-standing limitation in some of those motions. It's not something that normally just pops up randomly in your 30s or 40s, but that is certainly part of the overall condition that we see in terms of some of the limitations in the range of motion. If you have a labral tear and it's painful, that can also further limit some of your motion because you don't want to get in those positions because it hurts.
Thank you. If you have an injection for diagnostics or pain relief for impingement or labral tear, are there limitations on activities after you have the injection?
Sure, good question. So in general, no. These injections are performed with a little bit of numbing medication that lasts for a few hours. That first few hours or first few days, we don't want you being super active and doing a lot of high impact things. But the injections themselves over time don't mask symptoms. They're not going to allow you to do things where you're doing damage and not knowing it. Their goal is to basically decrease some inflammation over time to hopefully make you more functional. And if you are feeling improved after an injection, you can certainly return to normal activities and see how your hip responds.
Thank you. Is it common to need a hip replacement after having a labral repair?
Usually not. If we look at the overall studies that look at hip arthroscopy, hip impingement, and labral tears, there is a thought process that patients who have underlying hip impingement, over time, as they impinge or bump against the rim of the socket, they can create damage of the cartilage within the joint, and that can place them at higher risk for future arthritis within the joint, which could then lead to a hip replacement. Part of the thought process in our treatment of hip impingement is to, number one, hopefully make patients less symptomatic and more functional today if they're having symptoms. And we may, on a longer term, number two, affect the overall health of their hip over their lifespan. We don't have the 30 or 40 year follow-up data for hip arthroscopy yet to prove that, but that's certainly part of the thought process. And I would tell you that the vast majority of patients who undergo a hip arthroscopy surgery do not necessarily need any further surgeries in the future to include future hip arthritis surgery like a hip replacement.
Thank you. What is the difference between an impingement and a bone spur?
So bone spur is more of a reactive condition that we normally see as a response to underlying osteoarthritis or arthritis. And so bone spurs or osteophytes occur because of loss of cartilage within a joint and associated inflammation with that. The hip impingement itself is actually related to an underlying formation of the bone while you were a child. So as your growth plates are growing, these bumps occur essentially in a subset of patients. And so there is definitely a difference between a cam impingement or hip impingement versus a bone spur itself.
Thank you. When you say that patients can return to full activity after 5 or 6 months, does that include doing sports like jogging or pickleball?
Absolutely. Certainly the goal after this type of a surgery is to get patients back to full function. And so once they've recovered, as long as they feel functional, they're allowed to return to full unrestricted activity. That can include running, jumping, really anything that they enjoy doing.
Thank you. If an MRI shows a frayed but not yet torn labrum, are there things that a person can do to keep it from tearing?
That raises a good point. When we get MRIs of the hip, we have to be careful in terms of how we interpret some of these findings. I would tell you that it's very common to see some fraying in the labrum as we get into our 40s and 50s. And so if I see an MRI in a patient who may have some fraying of the labrum, but they have no symptoms associated with that, I can reassure them that that's normally just a little bit of some age-related wear, and that by itself isn't necessarily going to progress into a true labral tear or be an issue for them. And that's where, really correlating what a patient is seeing in terms of their symptoms and what we see in terms of their physical exam is important for us. But there's usually not one thing that we can say, oh, you shouldn't do this or that in order to then protect the hip or the labrum.
Thank you. Is it normal with an impingement and or a labral tear for the pain to vary depending on the position of the body or the activity that you're doing?
Absolutely. We certainly see certain positions or activities being more symptomatic for patients. I would tell you a lot of patients do report that they have some deep groin or hip pain, particularly with prolonged sitting. So oftentimes just long car rides will start to irritate them. There are patients that will see more discomfort as they are more functional. So if they're going on a long walk, they're working out, they'll have some resultant hip pain associated with that as well. But it can be quite variable. You can have days where, things are better than others, if you will. And some of those activities or positions can then exacerbate the underlying condition and cause it to be more symptomatic.
Thank you. Does this usually happen in one hip or both hips?
Yeah, so it's interesting because we're made symmetrically. And so most of us, if we have a cam or a bump in one hip, we're going to have it in the other hip. That being said, not everybody who becomes symptomatic in one hip will have the other hip be a problem for them. And so even if we see the bump on the x-ray, we really let the patient's symptoms guide us in terms of whether or not we need to treat that. I do have patients certainly that end up having hip impingement in both hips and a labral tear in both hips that we address surgically in both hips. But I have a fairly high subset of patients that have one hip that becomes symptomatic and the other hip never bothers them.
Thank you. If someone is symptomatic in both hips, do you do both hips simultaneously during surgery, or is there a waiting period in between?
Normally, we don't do both hips at the same surgery because there are some activity limitations associated after surgery that are hard to participate in if you've had both hips operated on the same day. There are some studies that show it's probably safe to do that, but the vast majority of us will address one hip at a time. We will usually allow for some overlap in terms of the recovery. So for myself, if I have a patient that has both hips affected and we are planning to do surgery in both hips, we'll address one hip, make sure that they're recovering appropriately over that first 6 to 8 weeks. And as long as they're seeing good progress in their symptoms and function, we can then address the second hip within that first 2 to 3 months after the surgery so that they have some overlap in their overall recovery.
Thank you. Do PRP injections help with labral tears?
That's kind of a complicated question. It's a good question because certainly we're seeing more and more use of what we call orthobiologics, or these injections such as PRP, which stands for platelet-rich plasma, which is where we take some of the patient's blood, spin it down to get rid of the red blood cells, and we're left with the plasma, which is basically rich in platelets and some other chemical factors that can aid in both healing as well as in anti-inflammatory effect. I would tell you that use of PRP injections for hip impingement or hip labral tears really isn't indicated in terms of what we see with some of the literature for PRP injections. I don't use a lot of PRP injections, certainly in the hip joint in my practice, because it doesn't usually result in a long-term fix for things. Unfortunately, most insurances don't cover the cost of a PRP injection, and it can be fairly costly for patients. And so I would tell you that it wouldn't be the wrong choice to maybe try that, but it's not something that I would normally recommend in my practice because of the lack of long-term results.
Thank you. We had a question come in of, can someone have a labral tear after they've had a total hip replacement?
Good question. No. So part of a total hip replacement is to basically clean out the old cartilage within the hip joint and replace the joint, the socket itself, with a metallic and plastics type socket. And so patients don't have any labrum anymore after a total hip arthroplasty. There can be some other conditions around the hip joint after hip replacement. Specifically, I see in my practice patients who have some chronic pain from their hip flexor tendon, the iliopsoas muscle, that can cause some persistent groin pain after hip replacement surgery.
Thank you. How long after the labral repair surgery does the pain usually stop? Is it pretty quick, or is there some pain during recovery?
Yeah, so most patients certainly have some soreness that first few weeks after surgery. I would tell you, I think most patients are pleasantly surprised that it's not as painful of a recovery as they had anticipated. Most of my patients certainly will come in within the first month noticing a difference pretty quickly in terms of their daily hip symptoms that they were having. There's certainly some soreness of some of the muscles around the hip as they progress with their healing process. But again, usually within even 3 to 4 weeks, the majority of patients are off their crutches, walking pretty normally, and feeling pretty confident in how their hip is responding.
All right. Thank you so much, Dr. Ellingson. That is all the time we have for today. Would you like to close?
Yeah, I'd like to thank everybody for joining us today. Certainly, if we didn't get a chance to address your questions, or you think of any questions here in the future, please do submit them via Facebook, because we'll hopefully have a chance to answer some of them and respond to them in writing.